Hello everyone, it's Chris Noel here with Cooper Critical Care. We're going to do a CT surgery sim. Very exciting, very fun. And so I think to start off, we probably need a first year volunteer. Get in there, Greg.
One person.
First.
Gloves or no gloves?
Gloves.
You can wear gloves.
Alright.
Alright, Greg, so you're on the blue side today.
Okay.
Our team is Doctor bleeds a lot is sending you their patient. So this is a 65-year-old female underwent emergent CABG. Initially he was going to do CABG with 3 grafts, but decided to add on 3 more just for style points. Long time on pump. Hey guys, welcome. Long time on pump. Comes out, no issues coming off pump, and they're here in your ICU, and so they're coming to evaluate them. So they, when you first come out, you notice that one of the issues you notice. Oh, you're up here. Can you read? Let me get over.
She's sliding my way. Hold on a sec. I'm tethered to the wall. There. Like, can you make it all the way to the wall? Nowhere to stand up.
Yeah.
Very good. Lots of floats.
Okay.
Lots of hazards.
Okay. Hold up. Okay, so everything's going fine, but you notice that it's a little juicy.
How juicy is a little juicy?
Really put out 100 cc's in the last 10 minutes,
Okay.
and it looks like it's continued.
Okay.
What kind of things how you want to know about them? What kind of things you might want to do to help them?
Having a rotem would be nice.
Okay, sure.
Quite
I'll write
helpful.
them.
So that'd be nice. Baseline labs, if we have them post OR, would be nice.
Okay. Hemoglobin was 10. INR was 1.2. Platelets were 200.
And what do vitals look like?
So she's blood pressure is like 80s systolic, on about 15 is more happy. Had bumped it up from 10 when they came out.
Yeah. At this point, I'm probably calling CT surgery.
I'm in the OR. I'm still in my corner. Don't bother me. Dr. bleeds a lot.
Is she still vented?
She's still vented, yeah. So what are kind of like so when a patient comes out of the OR, you may not know this, but maybe become spot, but kind of what are the two main, how do we try to define like bleeding? What are the big categories we're thinking about when someone comes out of the OR? So somebody might bleed, but it's not related to surgery, so how do we? Yeah. Yeah.
Shout it out for Sandra.
Sandra, check for some coagulopathies. Remember the medicine stuff.
Alright, so what are some things you want to know? So I think Greg asked for some of them.
I would grab just a regular old CT, EMP, pressure calciums. I don't know what kind of they got.
So they got 500 to cell saver.
Okay.
Okay, sounds good. Right, so you want to look at your coagulopathy with traditional parameters. You ask for a rotem and other extra tool you can have. What about CT surgeries might you, in terms of physical any coagulopathies? Usually going on pump, couple on pump. Okay. You may not know it. They're often cold, right? So you have to warm them up. So good. So those are all things. So you correct any coagulopathies, warm them up. Acid-base status is another one. So often we're giving, per protocol, we're giving patients bicarb. One of the reasons we do that is to try to help to correct acidosis that can potentially prevent worse kind of medical bleeding, coagulopathy. And then, all right, so you correct all of those things. Anything that we can do for this patient if they're still bleeding to kind of slow things down if it's a medical bleeding?
Medical bleeding, warm them up if they're cold.
Okay.
Acid-base. And then products based on what their need is, potentially, whether it's cryo or...
Okay. Anything else from history that you want to know in terms related to medical bleeding and product? In terms of
medication
function?
she's on. So
So-
if she's on dual antiplatelet or an actual...
So Plavix or dual antiplatelet prior to surgery is a big one, right? So an emergent CABG might not have had the appropriate time to wash out. We recommend 5 to 7 days off Plavix therapy, but we get patients sometimes who don't have the luxury of being off Plavix for that long, right? Very good. Anything else?
And you just your coagulopathy affected by blood and your intake. And the other patients that are like protein C, deficiency.
That's when you when patients actively bleeding, you sit down, you open up Harrison, and you start going through all of the coagulopathies. Totally, right there with you. Luckily, you have all that plugged right into your brain already. But for me, unfortunately, I had to sit down and go through the textbook. What else? So while you were trying to think through things, and is there any way to temporize bleeding? This is what Dr. Noel was getting to.
Okay, so you're stripping the chest tube. Why do we strip the chest tube? Okay, here's the time to think. The other reason, if they're bleeding a lot, right, the last thing you want is that chest tube to clot. The nurses are really good at continuing to strip the chest tube aggressively as they come out. That's not going to stop the bleeding. So you think about where we're bleeding from. So any other second years want to chime in?
The increase in traffic pressure.
There you go. Very good. Very good. So things you can do to do that are either increasing your tidal volume or increasing your peak or both. And here different surgeons may have a preference based on their beliefs of how that affects their grafts and things about which one they want to do. But in theory, either one of those would decrease your intrathoracic or increase the intrathoracic pressure and decrease that potential space for bleeding. So good. All right. So you're doing all these things. You're transfusing, you're correcting your coagulopathies. The patient remains hypotensive. The chest tube output is kind of slowed down, but you get their hemoglobin back, and it's 6. You've already given them 2 units of blood, and their pressure requirement continues to go up, but their chest tube output is significantly slow. Okay, so stat output says that you can't see much. Okay.
You can't see anything at all.
Yeah, there's not much you can see. There's air. So a lot of these patients that come out, you can't see too much because they've accessed that mediastinal pleural space. A lot of subcutaneous air, and you can't get good view. So, okay.
Chest X-ray.
Okay, chest X-ray. All right. You get a chest X-ray, and there's a large pleural effusion on the left side.
And you have a drain there.
They do not have a drain. There is a drain in there actually, but it's not. Not much coming out the chest tube. So, all right. Sounds like the surgeon's out of the OR, so they're available by phone if you want.
Put it in the chest.
Yeah, put it in the chest tube, please.
What?
Don't put it in the chest tube.
You got this?
You don't need permission.
All right.
Surgical or pigtail?
We don't do pigtail catheters.
We don't do pigtails and dying hearts.
Dying. Big blood.
Okay.
Did you say the right or left side?
So it's on the patient's left side.
It's like cluster.
Yeah. I don't think the surgeons would like to give me a chest tube without gloves on.
Can we also balance out the confusion and make sure that it's entirely empirically?
Sure. Yeah, sounds good. So one of the tenets that is getting is for transfusion is right. If you're just giving them red factor blood cells, we can dilute our coagulation factor, which is also true if we get a bunch of cell saver in the OR. Maybe they're not quite as
So nice.
balances the kind of a whole blood equivalent.
So fires. What? Oh, I don't.
This is not the fancy chest tube
I
tray.
know. I'm like, where is everything?
This isn't quite the chest tube tray, so we're going to have to makeshift on
Okay.
different.
How do you make that those?
So for the second years in the room, so this patient has a
No,
large left
no.
pleural effusion, presumed to be a left-sided hemothorax post-CABG. Why would he
Can you
have?
actually put a chest in this?
Why does he have a left pleural drain, and why does he have a pleural effusion if he had a CABG?
Sees that there's decreased output from the
So don't
suit,
poke
right?
yet.
So
Okay.
Well, why
that's
is
what
there
I'm about to
why
ask.
is there fluid accumulating in the left chest post-CABG? Leaking is usually a good answer. Leaking from what though? So this is why understanding the surgery is so important, right? These are the things that Adisa will bring to your attention. The patient had a CABG, right? Why would there be
Do a dissection now?
why would there be bleeding into the left chest?
And also use blunt dissect with a big.
Basically, can't poke it.
So commonly,
At least it's not
so when
yet.
they do a lima, right, they have to go into the left chest to harvest that lima, right? So you can have bleeding from harvesting of that graft, right? That pericardial space is open, but that's why you'll have. So if the patient doesn't have an arterial graft, sometimes they may not come out with a left-sided chest wound if they don't do that lima. So that's when you're looking at bleeding into that potential space. You have to understand why did they even go into that space? Why is there a drain there to begin with? That's understanding the surgery that the patient has, right? CABG means nothing. It's what grafts were done, where did they connect, how distal were the grafts, right? How bad was the and how healthy is the anastomosis? These are the things that, if given the opportunity, you should be asking.
So, the thing is, keep in mind, right? They open the pericardium; it's usually open to one of the pleural spaces. So, if you have usually if one of the drains goes down, the other one maybe will compensate. But if everything's clotting off, and you have a large pericardial or a large pleural effusion hemothorax, perhaps decompressing that space will decompress everything else. So that's why they may advocate for chest tube before you kind of escalate from there. So, all right. So we're going to put in a surgical chest tube. So
No,
we're going to walk through. So we don't get to do these that often in our medical patients. They're been supplanted a lot by our pigtail catheters. So why don't you just walk us through, Taylor? Maybe you can tell us, and you can get help from the audience. Where would we go with our surgical chest tube?
X-ray line with the intercostal space. You want to go above the rib.
Okay.
Which space there?
No.
You said between fourth and fifth.
Fourth and fifth?
That's why I heard.
Yep.
I know it's over here.
Right, and where in terms of axillary line?
Is it?
Yeah, no, you're right. It's medial.
So what kind of other landmarks? So for me, there's
no shoulder.
yeah, the shoulder's good, right? So always think about like where's the nipple, because the nipple's really like usually aligns with your fifth intercostal space. And you may say, well, if there's a lot of tissue there, usually if it kind of falls to the side, it will also still align with the fifth intercostal space. So go a nipple or slightly above, and you're usually in a safe zone. So kind of there's a triangle of safety, goes from the axilla along the mid-axillary to anterior line, and then basically the nipple or the intercostal space.
The memory full, yeah.
Here exactly.
The borders of that triangle are your
And then you do
Like a vertical incision.
vertical incision.
As in like anterior and posterior.
Yep, goes down, up and down.
This way?
Yep.
Do you follow the line of the rib, or do you just
So what you can do if you want to be really safe about it is you can actually cut to the rib.
Yep.
So cut down onto the rib, and then just extend it. It doesn't have to be a huge incision, but you want to make it big enough that you're actually gonna be able to use. There we go. So the goal here is not to cut into the pleural space.
No.
It's really just to expose that subacute tissue and So then you can use a Kelly to actually pop through.
You like put your finger in there, and then use the Kelly to open up.
You're gonna blunt dissect. So you're gonna kind of open that space.
I use a curve.
And so then
Yeah.
usually you curve it.
Just a little one, usually a little bigger.
You open up.
Yep. So kind of spread.
What is this made of? I know it's a person. Alright, you like keep dissecting down.
Okay.
How do you know you get to the pleural?
So you're not gonna dissect in. So once you get in a good way, so you dissect down where you're in the between the ribs. So you're gonna get your. So take this, and now you don't want to hold it like that because you can pop through and you don't know where you're going.
Table.
Usually I'll use like my finger as a
Oh,
back.
that makes sense.
Yeah, and then you can kind of put your weight into it as well, but a lot of times you'll have to.
Oh, you can kind of feel where the rib is. You're gonna go right over it, and you're gonna push and pop into that space. There you go. You popped in. Okay. So now you're gonna spread and come out. So don't push in. Keep coming out and spreading. Yep. And usually I take two hands and kind of spread
But a
like
lot of
that.
times you'll underspread, and you'll have trouble passing the tube, so you really have to like open it up and pull while it's open to open up that space. Yeah, usually literally two hands on.
Oh,
Yeah.
wow, that's
Yep.
pretty
Open
aggressive
and
on
pull.
someone's chest.
Exactly. These are not subtle.
Okay. So now take your finger and you're gonna feel in there. You're gonna feel over the rib, and often you'll feel the lung right there.
Yeah,
Feel the lung?
I assume this is the one.
That's a simulated lung.
This is simulated.
All right. So now you want to just kind of like feel around with your finger. So I usually do kind of like a 360. I'm gonna be cautious if it's a patient who's a trauma patient because they can have broken ribs, but I'm gonna feel around that space. Okay. You confident you're in the pleural space?
Yeah.
Okay.
That's my one.
So now you want to pass it over. So you loaded your Kelly on there.
Yeah.
Yep. You're gonna pass it along where your finger is. So one thing I like to do just to make sure I go in the right space is if the hole is big enough, keep your finger there and you
Ah.
can feel it kind of sliding next to your finger right into where you need to go.
Yeah. It's not like big enough hole to do that.
Okay.
It's usually the limitation, you gotta make a big incision in the skin for
I
the
will do
finger.
that next time. Then you just pass this.
Okay. Yep. And then once you're there, then you can come off with your Kelly. And as you go in, a lot of people say spin kind of externally, so spin away from the patient. Other way. Outward. And as you go in. So how far are you going to go in?
Another 15 centimeters?
I'll go 10 to 12. Don't ever go more than that.
10.
Okay? Very good. Then you're going to hook up to your Pleurovac.
This looks very full. Doing the lower back.
Oh, I don't have another one. But okay, you hook
Oh.
up to your Pleurovac.
Okay.
Okay? And you get 500 cc's out. And it's still coming out.
That's not good.
All right. What are you going to do now?
I mean, that at least begs the question, did they lacerate something inside the chest and it's bleeding now into this pleural space? If I've corrected all the coagulopathies, if I've accounted for medical bleeding, I mean, I hate to call you and be like, there's 500 cc's, I just got a chest, the chest tube is clogged. The other one is clogged. I'm concerned that there's an active bleed.
Yeah, so right. So this is a lot more than you expect from a simple coagulopathy, and even if it is, it's like very concerning, right?
Yeah.
All right, so you're getting in touch with the surgeon, and he says, you know, Dr. Bleeds a lot, says, I want you to give a factor 7.
Okay.
Okay, so you give factor 7,
Mm-hmm.
and the bleeding all stops.
Hooray!
Yeah.
What happened?
Well, they're still pretty hypotensive, and becoming increasingly more hypotensive.
Are they out of blood?
Huh? There's more blood coming.
I mean, did you check a chest x-ray after you put this in?
Yeah, it looks fine.
Okay. You're still hypotensive, can't get good views. Do you have a swan in?
The swan's in. The PA pressure is systolic is 5. CVP is -5.
more product.
Yeah, it sounds like they're
Okay.
bulimic. I just need to keep
Okay.
pushing. Probably 1 to 1 to 1.
So how do you going to get product to the bedside at this institution? What's the fastest way to do that?
Call it trauma pack.
So trauma pack, and then if you need to, so just so the trauma pack, you call for a trauma pack. It comes up with balance of products in a cooler, right? So you can get that at the bedside. If you need more product, you want it to keep coming and not having to keep calling, you can activate massive transfusion. They'll just keep sending it until you say no. So.
Oh wow.
But the fastest way, the kind of easiest way to just get product up here is get call for a trauma pack and have someone go down and pick it up. All right, cool. So you continue to do a transfuse. They're becoming more and more hypotensive now.
You have the surgeon coming in.
Yeah.
He is.
Oh, look.
He's on his way.
He's not.
And pressers? No?
Yeah, you're on 90 of Lumifed,
Oh! Anything else?
20 of Epi.
Okay.
So they still have a pulse.
Yeah.
He does.
Holy.
Although suddenly he goes into V-Fib.
Then you have to correct the chest, don't you?
Okay. Anything else before that?
I mean, you could shock him.
You shock him, right?
Yeah, you could shock him, but I feel like I'm going to be cracking his chest.
Probably right. Probably right. Okay.
Getting things ready to shock.
So exactly. So this is kind of talking about cardiac arrest for surgical for cardiac surgery patients. So before we go further, what kind of do you know of any differences for cardiac surgery patients versus medical patients in terms of how you treat arrests?
You don't get on the chest, you don't put it very crack the chest.
Yeah, so there's three main ways we need to think about cardiac arrest in CT surgery patients. So one is arrhythmia. So the most common type of arrest is V-Fib or V-Tach arrest. So let's say this patient wasn't actually bleeding out of his chest tube. Let's say they just came out and they're doing fine, and then they suddenly went into V-Fib. So what would you do?
Immediately shock.
Immediately shock. Okay, they're still in V-Fib.
I would start a little bit here.
Can you overdraft these?
Yeah.
So
Okay.
this is a good thought. So you didn't do that. So, but yeah, it's a good point, good thought. So if you look at kind of the guidelines from the American Thoracic Surgeons, what they advocate for is shocking 3 times in a row without compressions. So defibrillate.
How much?
I would go max.
Okay, just max those 3 times.
Yeah, you're defibrillating. So you defibrillate, still in V-Fib. You defibrillate immediately, still in V-Fib. You defibrillate immediately. Then at that point, then you can get on the chest while you're preparing to then open the chest. So that's shockable rhythms. If you have a patient, let's say they're sitting in a chair, and they suddenly go into asystole.
It will happen to you this year.
Like to start CPR on with the thoracic surgeon on. No.
What else do all these heart patients have? And this patient included.
They all have a pacer wires, and they all have.
Yeah, so they have epicardial pacing wires, right? So pretty much universally, they're going to come out with epicardial pacing wires. So for this reason, that patients post-cardiac surgery, particularly valve patients, can go into complete heart block, and also occasionally we have no underlying rhythm. We go asystolic.
Happened yesterday.
Did it happen yesterday?
Yep. Bed 7. I was like, thankfully,
Okay. Very good. So let's say we knew that they had no underlying rhythm, and they were in a chair. So you run in the room. What is one very simple thing that could be going on that you can save their life?
They just have sync. Can you get that one on the
Yes,
floor?
they just syncopized. Yes, they're syncopized because they have no heart rhythm going.
Turn the pacer on.
Turn the pacer on. Exactly. Okay, so this is the
Is that
battery.
turned on?
Yeah.
When did they turn it on?
The battery ran out. So good. Yeah, right. So you want to check the pacer, make sure it's on. So simple things, very quick things being common. So the other thing is that make sure that the wires aren't pulled out.
So, Taylor, can you hold up the can you bring the
Yeah.
picture box in the video?
our pacer box. Here's the hookups that you should be seeing 2 of these coming out. You should make sure that they're intact. This and that these are in. Anything to be replaced needs to be replaced. So pacer box. And then make sure it's not that it's fully charged, which it is not.
Okay.
So does it matter if it's in the A port or the V port?
No.
Okay.
I was told at least, but does not matter as long as they're in.
That's right. And in that scenario, you have to unlock it and turn the amplitude all the way up, right?
Yep.
There's also a red button on the top of this pacer box, and you can hold it up to the camera so everyone can see. And what is that button?
I think it's an emergency button.
It's
Right?
referred to as the oh shit button. If you hit that, everything goes to max immediately.
Oh,
right? So
that's
that
handy.
would be your go-to button. Okay.
Yeah. And we'll talk about pacers in just a minute, but it's DDD. It's going to be asynchronously pacing both the atrium and the ventricle at the maximum
Sure, capture.
maximum current that it can do.
Sure.
So it will get rid of any sort of problems with sensitivity or capture threshold or anything like that. All right, so good. So you've now managed asystole. So now let's say it's PEA, and they're pacer dependent. They're fully paced. One more caveat. So this one's not N2, but if they're paced on the monitor, you see pacing spikes.
Yeah.
But you see that there's looks like maybe there's something there. So if they're in PEA, you actually want to turn the pacer, turn it off so that you can see if there's anything underneath. If they're in VFib underneath it, would shock for it.
Yeah. Makes sense.
So those are the 3 things. So VFib, shock, then CPR open chest, asystole, pace if it's available. And then if can't pace, get on chest, if you can't pace, put it open chest. And then number 3 is if the PEA, but it looks like they're paced, turn it off so you can see if there's underlying VFib, get on chest and CPR.
And pulseless V-Tach goes under.
Or open chest.
Yeah. Okay.
Yeah.
That makes sense.
So, and common things being common, so the most common reason for an arrest to happen, other than just like the pacer box coming off, is that there's something surgical that needs to happen.
Mm-hmm.
So that's why all the end algorithms end with opening the chest up.
Yeah. Makes sense.
So one can facilitate finding out what the problem is to fix it, and then additionally, then you can also do internal cardiac massage. All right. So, so this, getting back to our patient, so they've bled. You put in the surgical chest tube. The patient's blood pressure continues to fall. You continue to transfuse blood, and suddenly you lose a pulse.
What's the rhythm?
The rhythm is PEA. It's sinus rhythm, not paced.
So take the pacer off. See, it's true PEA.
Sinus rhythm, yeah, PEA.
Okay. And then jump on the chest, start CPR, get ready to open the chest.
Yeah, so if you have availability to open the chest right there, if you can avoid doing CPR, great.
Be the best.
That being said, with all these algorithms, if there's a delay in that happening within a minute, 2 minutes, CPR to help to perfuse them. But obviously, it's a fresh heart. Doing that, if you have the availability to open the chest, knowing what we know about why this is happening, then if you can get away with
Cardiac massage.
expeditiously opening the chest, then that's the preferred thing to do. All right. Very good. So, we need another volunteer.
Jump in it.
Huh?
Says you jump in.
There you go. All right, Caitlin.
Are we starting something new?
So this patient is now in full arrest, and we think that they're in clinical tamponade.
So if you're not sure what to do, start milking chest tubes.
There's some
Think about
answers
it.
like say that. I don't know what to do.
So we think he's a tip, not you need a pericarditis.
Okay, so you try that and your needle clots off immediately.
Okay. So now we're trying to open it to.
So do you think like a pericarditis is going to be is it going to fix them, you think?
No.
Yeah, probably not, right? They're bleeding this much. It's not. So I wouldn't waste your time with that if it's a fresh cardiotomy patient who's arrested and everything technical. So if you look at kind of guidelines for cardiac arrest, they recommend up to like 14 days. And that's a long time when this can happen. And obviously we're in touch with the surgeons about what they want us to do. Like we're not like just doing this on people who have a cardiac arrest that maybe, you know. So okay, so you call the surgeon. He says, I'm on my way in. I need you to open the chest now.
I would ask someone his wire asks someone that's done it or.
Okay, so trauma, you call trauma overhead, but they've been getting slammed. They're all in the OR.
Okay.
They're dead.
I mean, so
I guess I'm just.
yeah, like,
well, it's
there's
wire.
fresh
It comes with a set.
sternotomy wires. Like you just go
I would
through.
just.
You just go through the.
Is there like a
surgical
hole?
incision.
Yeah, say there's a kit and then you can cut the
There's
wire.
already-
Yeah, exactly.
Wires.
So first thing is where
Yeah.
are
I
the
like it.
things that you need in your ICU, right? So first step is knowing where everything is. So where is everything that you need to deal with just about every situation we talked about right now? All spare parts and everything exist in the
Heart cart.
heart cart. And what is the code to the heart cart?
4829.
Oh.
That's a good idea though.
It's 2224.
Right, so CABG. And the heart cart exists where right now? Because it moved position. I just need to make sure everybody in the room knows where it is. It is in the clean supply room right now. Okay, very good. So it has, and you know, we can certainly bring it in. We can go through each individual tray, but you'll have everything sequentially to work through what you need for the trays that you need to go in and rescue this patient.
Are the heart
Sorry,
nurses
Brenda.
trained to help us with this?
What's that?
Are the heart nurses trained to help us with this? Like, will they know or something?
So it depends on how senior your heart nurse
Okay.
is, without a doubt, right? You know, if yeah.
So we're yelling
But
for
certainly,
you.
like if you yell out what you need,
Guys, got your breath back on me.
your critical care tech will be able to bring it to you. Just like Phil brought us everything we have here today. Just stay calm. Go sequentially through your systematic approach to the bleeding heart, and ask Phil for what you need, and he'll bring it to you. Okay, you have it.
All right.
So this is your thoracotomy trays here.
So I don't know which ones are.
You're good. So what we're gonna do essentially is we're gonna open the chest. So we're gonna open the chest through the midline sternotomy. So you can take down this dressing.
Okay.
So like logistically, if chest compressions were started, we're getting the stuff ready to crack the chest. You're like pouring iodine over the non-sterile hands.
Yeah. So you're doing CPR, right? You're getting sterile. Somebody's doing CPR.
Okay.
Somebody else is splashing with betadine and they're doing CPR. As soon as you say I'm ready,
Then they take
you have your drape. They come off the chest, squirt again, drape down. You resume CPR,
Okay.
and then handing you stuff, instruments. Once the person's ready to cut, then come off the chest and cut.
Okay.
How do you break this sternotomy wires?
Good questions. So you're gonna have the wire cutter. So actually, it doesn't come in this kit. It's in the heart cart, but I have a wire cutter for you. So why don't you take down the dressing?
Okay.
So you need, how many people do you need sterile?
At least, I would say at least two. I mean, at least two.
Because one is doing compressions while you're doing stuff, but also probably maybe have someone else.
Yeah. Okay, so now you have the skin there.
You want to give us a second?
So don't take that off. That's part of the skin. This is the skin.
Okay. So then do you
Well,
cut
also,
first and then I cut that?
the one problem with our simulation is that this is the
So you'll
this is
see
the
when
main
they,
wound that was
yeah, you'll see when they come out, right? They have closed chest, closed skin, all right? And you're just gonna have to cut through, expose the sternum and the wires and go. So we gotta cut first, expose.
Essentially, I would be on that side, Brady.
And you just open cervical side.
Yep, you're just opening this over the side.
I'll get the
So
wire
it's all
cutters.
just gonna flop right open.
Wires.
Just
He's gonna get wire cutters for
Watch your fingers. It's real, but it's not real, but it's real enough.
I don't need anybody to pull up the wires because it's the wire yeah, she's gonna pull
What, talk through what you're doing, right? So you expose the sternal wires and you're turning them all up.
Yep. So I'm pulling the
Greg's pulling them off.
twisted part out.
Wow. There's some cool twist ties.
Off the sternum.
Well, then you
Like
have
under here. Yeah, so from here, so I can get under there.
Yep.
And the wire cutters don't look much different than that.
Okay.
They really don't. Yeah.
It's like we see the DeWalt drills in the ortho suits. God, those are the
Yeah.
whole thing.
No, those are
Yeah, you don't,
foil
yeah, you
cutters.
can cut, you
Okay.
don't have to pull them out, but try to
But
pull them out when
the
you cut
twist-
them, yeah.
Whereas, as those,
Otherwise you'll
like
get
the ones in
stuck,
the
yeah.
street, are those as
Oh, you
thick
can pull them out.
as
There
you
you
have
go.
in the
Good.
sternum?
No, they're not quite as huge as that. Those are from Home Depot.
Okay. I mean, could be.
Yeah.
What is it? This is so clever. Yeah, so you need at least two people.
Good.
Okay. So now,
And then how do you separate it?
one second.
Putting together the better.
Better, doctor.
So in your full open thoracotomy tray, which is on the bottom, the D says it the last. It's the last tray. We'll bring in the heart card in a second. I think it's the last bucket. You'll have your rib spreader in there. Yeah, it'll say open thoracotomy tray, and the rib spreader will be inside.
Hopefully the sternum is almost here.
Bridge traffic.
Yeah, I'm getting my custom license plate done.
These are James. I feel like they never go on right. I always forget which one it is.
Yeah, so that's right. So this is gonna go, either gonna go down.
Yeah. This has to go on.
Yep.
Does this have to go on first?
Yeah, it does.
Yeah.
I'm gonna make sure to bring it all together first.
And so it's not here.
Where's the chest and the head? Which orientation do you do?
Mhm.
Which orientate like that down?
So you want that out of your field. So whatever this is gonna be out of your field. So it's. And probably if you're coming in from that side, that. Yeah.
And I feel like that's gonna be a fun way.
It's going the wrong way.
Oh. Is that Jello?
That's blood, man.
Do you have fun making this?
Jason, this is a Jason model.
This is. Your kids get to play with this afterwards?
Alright.
Open up and you can answer that.
So often, alright, so Jason's the most experienced, Dr. Bartok is the most experienced person in this room with this, but essentially with this, often to alleviate the tamponade, this is all that needs to happen.
Yeah. That's a good point.
All that needs to happen. If nothing else, this is it, and you'll have, what you need to have is there's a suction catheter as well, just to suction out the clot and try to evacuate the clot. So there are steps in terms of
Pericardiums are already open.
pericardium's already open.
Okay.
So you're not like snipping the pericardium, things like that.
Wait, do
So-
they leave it open?
Yeah. All right, so you've accessed it. At this point, if you see clot, you can suction, kind of gently bring the clot out. But you don't even have to go further than that. And often, in this institution in particular, there's people in house, and you don't need to be going any further if this were. And even when this would happen, it's a pretty extenuating circumstance where you're the one doing it. But this is kind of all we need to have done.
Yeah, opening the space should be enough to alleviate the pressure to allow the patient to perfuse, right? Before you get in there and start digging around. But yeah, if you take off, 20 or 30 grams of clot, it's a lot, right? And some of these cases, I mean, you think about, and this is the argument, and why you really have to know what's going on and have a good assessment of whether or not you think the patient is tamponade, because, a surgeon's going to argue back that my patient really can't go in the tamponade. They have an open pericardium, they have pericardial drains, and they have their left chest open to their left hemithorax, right, where you can drain into one space, you can drain out another space. How is my patient tamponade? And sometimes, focal tamponade over time, is enough to cause it. So by opening that space, that's all you'll need to temporize the situation, allow the patient to perfuse, get them to the OR so they can surgically repair, right? Before you get in there and start accidentally put your finger through the RV or something like that. Try not to do that. Bad form.
Yeah. So remember the walls are very thin. There's the fresh surgical sites. We can cause more harm than good by kind of digging our hands in there. But since this is sim, we get to dig our hands in there.
That's right. Evacuate the clot. It's edible.
Okay, so deliver the heart. So you're going to gently bring your hand behind the posterior aspect of the heart. There you go. Okay. So how would you do, if you had to do internal cardiac massage, how would you do that? You can bring it out just so you can show everyone.
Oh, it's wires right there. Yeah, I feel.
Very good.
Strawberry or cherry?
Cherry.
Did you do a cherry? Chris made it. Oh. Kept some for himself, for the baby, and the rest went to Simba.
Taylor,
I
wonderful
can
chest.
smell it.
What?
It's a wonderful chest, kid.
Thank you. That's didn't do enough though.
Is there CPR happening while this water evacuation is happening?
I assume so.
So, I mean, in reality, if this is tamponade, you open the chest, you probably have enough to, for if the patient's in PEA, hopefully you'll get ROS just by alleviating the tamponade. But if not, you're going through the same algorithm. So right now,
But Mira, if they're cutting and opening the chest, nobody's doing CPR.
yeah, there's nothing happening until you're. Oh, that's why you got to be fast. The reason why we're in here is because, in terms of butt puckering moments, we talk about them in critical care. This is probably number one or number two. You got to move fast. You got to know what you're doing. You have to be familiar with all of these tools that you probably never used in your life. They will be your rate limiting step, right? Getting what you need, then actually having the muster to go in there and do it, and then realizing you've never put a rib spreader before and nobody in the room knows what you're talking about, right? So that's why we're here. But yes, move quickly, get it out, alleviate the tamponade, and if you need to, then you get to squeeze the heart. It's something that everybody went to med school to learn how to do, right?
So while we're fumbling,
Massage.
Huh?
Up and down.
While we're
Just
fumbling with
palms.
the rib
It's like
spreader,
What's that?
while we're fumbling putting together the rib spreader,
What's that?
while we are fumbling putting together the rib spreader, is it safe to
No.
manually?
No.
Yeah, don't do it. You're gonna cut your hand. Don't do it.
Yeah, those ribs are sharp, number one. And so I would never advocate for getting your hands in the patient's chest and manually open. I would get the rib spreader together. Be safe. Put your team first. Patient's dead. Trying to get him,
Yeah, and probably in reality, it's harder to. I mean, it's already hard to open this one.
Yeah.
I bet it's
So,
even harder in real life.
The tension that it requires to get the chest open is pretty significant. Yeah.
All right. Okay, so how are you gonna massage the heart?
I mean, you're in great shape though.
Like, Brian, come here, I need to.
All right, so let's talk about massaging the heart, so you don't poke your hole through the aorta by accident. So how would you do it?
So you just said this way. You go like this.
Yep. So flat hands, right?
That's gonna be inside the chest.
So palms of your hand, and which way are you going? Apex to base, base to apex, and why?
Base to apex.
So which is it? Apex is here.
Yeah. Oh, sorry. So apex to base.
Apex to base, right? So you're trying to like inject the LV essentially. So yeah, so flat, no fingers to go through the heart. You're good.
And Brendan was saying we have like the actual cardiac paddles.
All right, so that was the next question. So now if the patient goes into VF in your hands, right, you'll be able to make that diagnosis without looking at the monitor, right? Now are you going to be able to deliver a shot with an open chest? And the answer is no,
Right.
probably not effectively. So in the heart part, you have your intra cardiac paddles. We don't have those on us, do we?
They're in the heart part.
Yeah, we didn't want to mess those up.
Where do you attach them to? Just
Huh?
a regular,
They get attached to the Zoll.
just the usual.
That's, yeah.
Should you turn this off? Did you turn this off,
Turn what off?
the pacer, while you're doing this?
Probably reasonable.
I just like,
Probably not enough to
You're not
hurt
gonna,
you.
yeah, you're not gonna like electrocute yourself. No, but yeah.
I mean, she's not right now. It's on. So.
So is the voltage any different when you're using paddles?
It is. It's a good question.
Yeah.
I actually, I don't know the answer to that. I would suspect it'd be something small, like
Yeah.
25.
50?
Yeah.
I thought it was 50.
50. Yeah, we haven't done it in a while because we only have one set of paddles up here, and I always feel bad asking the OR for the other, but I'm pretty sure it's 50 joules. Yeah. I have to look it up now. That you asked something. Leave it to Brian, ask the hard question.
I guess you could always try 50 and go up from there.
the 360 just like burn fire.
Okay. All right, Kaylin. I'm here to take him back to the OR.
Thank God.
But I got my license plate.
Cool.
I feel like it's always a pain in the ass to put together ours. Somehow always, one of them would always be, or you come together and then you're going backwards and then you're trying and then you're like, wait a second, this doesn't make sense. So you have to take the whole thing apart and like put it back together.
Alright. So I think we'll get everybody up and come up here and take a look. But why don't we talk about one other thing? Why don't we talk about one other thing that you might have to deal with, which sounds like you dealt with the other day. So why don't we talk about the pacers and kind of how they're working? So when you're taking care of the post-op patient, or one of the important things we want to know is if their pace is. So what do we want to know about the patient when they come out? with respect to the underlying rhythm, right? So how do we check for the underlying rhythm? What's a good way to do that? So turn. So what did you say?
You just turn it down, or
Turn down what?
sensitivity, or
So there's a lot of ways you can do it. What's recommended way is actually turn the rate down, because then you're not losing capture. Which you turn it off, obviously turning it off, or we may see it's pulling that wire out to the top. You can lose capture in theory, and you can lose capture and not get it back. So if you instead you just turn the rate down far enough, you can really kind of see what it is, if you're really going long. So that's really probably the safest way to do it. So right, we want to know what rhythm's underlying, right? So this is our asystole, we're asystole underneath. We have a lot, place a lot more importance on that thing. All right, so, okay, good. So what else do we want to know? What type of pacing? Good. So what mode is it in? And what kind of wires do we have? So what's different about this kind of the pacers in the postcardiotomy patients versus let's say a permanent pacemaker or anybody else is they have epicardial wires. So if you want to just grab the, let me have his gloves so we can grab the heart again. So they're actually in the epicardium, they actually sew them into the epicardium.
Yeah.
Took the, yeah,
Oh.
right.
Oh, that's right.
Take the heart out. Or hold these.
So yeah, so they're actually in the epicardium. So what we're trying to simulate here is there's a V wire and an A wire. So the V wires are either orange or blue. Correct me if I'm wrong, where did these go? Orange or blue, and if it's a ventricular paced wire, by convention it's going to come out on the left-hand side of the sternotomy. Atrial wires come out on the right-hand side, which makes sense anatomically. And then often, unless there's something wrong, the pacemaker should be set up that way that the ventricular wires are going to the V and the A on the pacer, but obviously that can get messed up. Okay, so these are physically on they're sewed into the epicardium. So there are so let's say over time, so we want to know how much current is required to actually generate either an atrial contraction or ventricular contraction. Right. So how do we determine that? Yeah, your milliamps, right? So what you want to do, so let's say the patient is in the sinus rhythm at 80, is you want to go up on the rate on the pacer box so it's above the native rhythm by about 10 beats or so, and then come down on your milliamps until you lose capture. So when you've lost capture, that's your capture threshold, and you want to set the milliamps to usually 2 times greater than what that was to give a margin of safety. So what happens to that? If let's say you left this patient on epicardial pacing for a couple of days, what happens over time? Yeah, scarring, fibrosis. So, and often that accelerates because the higher the milliamps that are required, the more scarring happens, and the faster that thing's going to run out on you. So knowing how much, particularly if someone doesn't have an underlying rhythm, knowing what their capture threshold is really important. All right, and then there's one other thing that we set on there that is helpful to know and to set appropriately to avoid other problems. I think I said sensitivity. All right, so what is the sensitivity? I think this is the most confusing term we use in pacing language. Yeah.
The threshold which is text underlined.
Yeah, exactly. So you might think, at least in my mind, the way mine works is that something is more sensitive if the the number, you set a number that's higher. But this is how it works. So T-wave here. Alright, so one of the things that we don't want to happen, right, is we don't want, if someone has normal sinus, a normal rhythm, or has a rhythm underlying the pacemaker, we don't want the pacer to inappropriately fire, because you can get RNT phenomena and then go into ventricular rhythms, right? So what we want is this pacer can actually sense when the heart is actually giving their own contractions. Depending on the mode you put it in, it can either sense when the atria is the native, there's a native P wave, a native QRS, or both. And so when it senses these appropriately, it's not going to, if the native rhythm rate is higher than what we set on the pacemaker, so let's say our heart's beating at 80, we set it at 50, then nothing should happen from the pacer box. We shouldn't see any pacing spikes. But if it's not set appropriately in terms of sensitivity, it might start firing at a rate of 50 while our native beat is going at a rate of 80, and then they're going to be interfering with each other. So when we talk about sensitivity, so we look at an EKG, right? What's on the y-axis? What's the units? So it's volts, right? Or millivolts, right? So the same thing with the sensitivity. It's actually the bar. So if you think about like a fence, it comes across and says, if the native electrical activity goes over that fence, then I will suppress what I'm doing with the pacer box. So if we set, let's say this is at, let's say it's 1 millivolt, right? If this patient has, this is 2 millivolts, then it's not going to fire. If it sees this, it'll see this, right? But let's say instead we set the sensitivity up here at, let's just give it, I don't know, let's say 5 millivolts. Patient's down here, then what's going to happen with the pacer? It's going to go off, right? It's going to pace. It's going to pace, and it shouldn't be, because we have a good rhythm here. So you have to come down with this until you're able to see it. Now, what if we set it too low? That number too low. We set it at 0.1. And what happens? It doesn't fire when it's supposed to, right? Because it can see the atrium and says, "Oh, that's a spike," and it's not going to fire. So how do we? So let me know how we figure out if that's working right. So so we only want to do this if there's an underlying rhythm, right? We don't want to check this if there's not. But so what you want to do is what thing you don't want to happen is you don't want to make it so that the pacer's firing asynchronously with the patient's own rhythm to risk an RNT while you're checking this. So you want to turn your milliamps down to the minimum, so that it will show you a pacer spike on the screen, but like it's unlikely to actually generate a paced QRS complex based on that. Right, so you put the milliamps to the minimum, so the current's the minimum, and then you're going to adjust your sensitivity from basically the either the most sensitive or the least sensitive, so the highest number, the lowest number, and gradually increase or gradually decrease until you see pacer spikes firing. And there's a light on here. Usually it says the sensing and the pacing. Right here. So there's a sense next to this, a pace and a sense. You guys look at the top, there's green lights going off. Those are the pace ones, because it's not sensing anything. So once it starts sensing the data beat, it's going to actually have a light go on there. So once you find when it's actually sensing, that's your sensing threshold, and then you're going to want to set it higher or lower than that. you want to set the number higher or lower than the sensing threshold? Higher? Okay. Lower. You want to set it lower because you set it higher, then you're raising that fence too high, even higher than where it was. So you set it a little lower, that gives you some wiggle room. That if their QRS is slightly smaller, then it's still going to sense it appropriately. All right, cool. So that's how we set our a pacer box.
Chris, do you check on every patient who comes out of the OR?
I would say that I am guilty of not checking that consistently on every patient that comes out of the OR at this current time.
So I guess my point being,
But the nurses do.
So we do check it
Okay.
when the patients come out, and nurses have to check it every shift. If they're not paced, they still have to check the pacemaker every shift if they're connected to it. For ABRs, we keep them connected to the pacer for 2 days. Everybody else, if they don't need it, we usually cap the wires the next day. And that's usually when the patient was systolic and we're running around looking for locks. But they are supposed to be checked. We usually do it, or the nurses when they come out of the OR.
and like how you mentioned when you reduce the rate so you don't accidentally lose capture, when you're testing milliamps and stuff, you also lose capture and no longer it's functional, like the wire, I don't know why that would happen, but like...
Yeah, so so you know when you're doing that, you know that there's a rhythm underneath.
Okay.
You shouldn't be doing these things if there's no rhythm underneath.
Right.
Make sense? So if you know there's a rhythm underneath, you know that if you lose capture, there's something there.
Okay.
How do you know if there's rhythm underneath? Like, do they come out of the OR?
Ask.
Okay, alright, this is the question.
Usually they'll tell you if there's anything underneath. Sometimes they say we have no idea their piece, we don't know what it is, but we always check it. Even if there is solid, just pause it for a second. If there's nothing, you put it back on.
Yeah, there's a pause button on the box. You just unlock it and you hit the pause button. But you don't. So if you're going and doing your exam in the morning, don't pause the pacer box unless somebody knows, right? And so you don't have all these people rushing in the ring if something happens, right? So, like, we're teaching you guys about these things so that you respect them and you understand their utility and how to troubleshoot, but it doesn't mean that you have free reign, just like the ventilator is going and start touching buttons and playing with and cracking chests. Talking to you, Bren. I know you're on the line. So again, it's like they just don't run in the room and just pause everybody's pacer box in the morning, but you'll know how to check for an underlying rhythm, but the nurse in the morning or the cardiac surgical APP will all know what the rhythm is.
Usually if they're paced and you want to check what it is, it's better to slowly go down in the rate. If you hit 40s, they're still paced. You can pause it, see if there's anything. But sometimes if you just pause it, even if they have something, they completely lose it.
Mm-hmm.
So I usually decrease the rate. As long as their pressure is stable, you can decrease the rate to 40. If they're still paced, there's probably nothing under there. But some people just go in and unplug it. Please don't do that.
Yeah. You can lose
Not
it.
good.
Same thing, pausing it too. And probably, in practically speaking, right, if you're at 40 and there's nothing there, like, do you really care if there's something at 20 or 15? Like, yeah. But yeah, to your question, the nurses are routinely doing, and it's something we need to be asking and doing with them. And I pay particular attention when it's someone who's, like, obviously if they're not paced and their rate's normal sinus, you're less concerned than if someone who's pacer dependent coming out of them.
Like bed one came out complete heart block the next day. He was sinus with first degree block. Sunday, we will put him on a beta blocker. Sunday night, he was just rhythm again. So we don't hold the beta blockers if they recover and their first degree block. We still give them, but they should be still on a backup pacer. Which hopefully, I think he was. It just wasn't on, which it really should have been.
How durable are these? Like, do we ever need to just do a different kind of pacing?
Yeah, you will probably at night sometime. That's typically when it happens. But they like if you look at like one thing I saw quoted was like at 5 days, like 60% of usually fail by 5 days. They're not that long.
They're not very durable.
Yeah.
That's one of the reasons why we keep the quarters in, because the wires
The wires
stop working. into the tortoise, you will have to change it to a different size, but it's easier in an emergency to change it than to do sticks. So despite what he says, don't take the tortoise out on a complete hard block patient.
Yeah, it's a really good point. And also knowing your surgery. I mean, I remember the last time we had a patient who failed to capture, wires failed, and had a mechanical tricuspid, which is like near impossible to get the flow to a transvenous through. So I think what we did was ended up manipulating position, held pressure on the chest. He was able to capture with like people holding on to him. He went to the cath lab.
All right, so let's say you are in the situation where it's starting to fail on you, and before you take a step to, or let's say you want to temporize them because they're bradycardic and they're a little hypotensive symptomatic with it. And maybe you kind of recognize that, hey, we need to go towards like a transvenous pace or something. Are there any things that you can do to use what you have to extend the life, or maybe troubleshoot if it's not working appropriately? So other than making sure that we're appropriate capture and sensitivity thresholds.
Can you swap the wires?
What'd you say?
Can you switch the...
Yeah, you can switch the polarity of the wires, right? So it doesn't seem like it would make much sense, but if you can switch, so you want to come over and show us exactly what that means, or somebody want to?
Yeah, just taking this out.
Going up a little bit.
Yeah, switch this. Bring up negative. Here, hold on. Pull it out.
Okay, hold on.
If they have no underlying rhythm and you have to switch those out, what do you do?
You hope you don't drop anything, you do it as fast as you can.
Got it.
So there's three ways to pace, right? So you have these. We can get these working immediately. But we have transvenous, which takes a little while to get set up, and then you can try transcutaneous to pace if you need to.
Sometimes the patient comes out and has sore orange wires. They're all ventricular wires. It's just when they're trying to make a wire, they don't work, they keep trying.
All right, so you switch the polarity. Okay, so that may work. And if that doesn't work, anything else we can do? Yeah, exactly. So there's two types of wires that the patients come out with. So there's unipolar and bipolar, right? So you think about, erase this thing. My heart. So if it's a unipolar wire, right? So here's our wire, it's coming out. This is going to our pacer box. Unipolar, there's only one that's in the epicardium. The other is grounded in the subcu tissue. Alright, so this is our... And so essentially that current is going through the patient's heart and subcu tissue to generate our electrical activity. Now there's also, so when we're talking about unipolar wires, they're not that common here, honestly. Most of them are bipolar that come out. The bipolar, so let's say this one doesn't work, right? So you reverse the polarity, it's not working. So this can be literally like an 18 gauge needle or suture needle, and often it's actually just hooked up right in here. So you can place a new one, so place a new wire through the skin, and then you can hook it directly into here. So actually, if you want to do that with this guy, so if we think about this one, right? So if this was a really this is a unipolar wire, then this should have this white one should not be in the epicardium; it should be in the subcutaneous one, right? So if we wanted to reground. That positive one is going to be our ground, okay? So we're going to put a ground it. So literally just put the needle into the skin anywhere. We're going to have like a straight needle suture, just put it underneath the skin. You want to actually stick it out. Just put it in the skin. And then you just hook it up into here.
Yeah, so usually the describe the alligator clips. Usually when you do alligator clips, where you can just put it right in.
Say that again?
So it comes with So you'll have So you can have an alligator clip that clips onto it, and then that will clip into that, as opposed to going directly inside.
Yeah, like a needle.
So you'll just clip the alligator clip to the needle going through the skin, and then plug that into.
How do you
Into
decide
the baser box.
which one you can disconnect?
You do one and then you do the other when it doesn't work.
Yeah.
Have you ever seen a crystal and adhesive like move lightning fast? Like when it comes to the basers, that's what they're doing. They're switching one. They switch really quick, then they throw a needle in and then establish a new ground, and then if that doesn't work, then they switch it, establish a ground on the other side. If that doesn't work, then we're transcutaneously basing, getting ready to float a transient baser. They're really good at it. They move very fast, but it's something that I can remember when we didn't have anybody on at night. It was something that I did like in the middle of the night half a dozen times as a fellow. Never really understood what I was doing, but just was really happy when it worked. You know what I mean? But important, Dr. Noel was able to sort of tell you guys all the things I didn't know when I was training. So I think it's really interesting, and I believe that the V wires, the orange wires, are unipolar.
Yes.
So
the orange ones are unipolar.
For your straight up CABGs, the surgical preference, one of the surgeons will generally always put in bipolar wires. But generally speaking, when you have straightforward CABG, even some CABG valves are just going to come out with that orange. When it only comes out with that orange wire is the V wire only.
Yeah, and so bipolar is essentially, it's all built into a single insulated wire. So you have your positive, and you have your negative, and it's just like traveling right here. And you have one single wire that comes out, and then it splits and plugs into that.
And somehow,
Little
don't
adapter.
ask me why, establishing a new ground will get that thing to work right sometimes too, and it doesn't make any sense.
So if you establish a new ground, you essentially turn it into one of these.
Into a unipolar wire.
So essentially, once you ground, let's say you have two leads, right? Take one out, unplug one, put a ground in, hook that up here. Then this one's just out in the doing nothing, but now you've turned it into a unipolar.
And it'll start working for you.
And the bipolar stuff is like one atrial, one ventricular, or
No, this is only in the
they're
ventricle,
both ventricular.
or only in the atrium.
Yeah, also only one of the surgeons tends to have atrial phase and then have eight wires in.
That's if the
Regular.
block and it's atrial based though, it's still screwed.
Yeah, if you just
Because the block will be below the level of that. So it almost always is useless to you when you're troubleshooting blocks. You're really just going after it from the basic. Cool.
Can we back up to the coding? What if, obviously they're going to be maxed out pressors, certain chest compressions, and they're just going to be pushing every, but you're not supposed to be giving a lot of pressors during a post-cardiac arrest, or everywhere especially, right?
Yeah.
So how do you manage the pressors as you're cracking the chest?
I mean, I think you're trying to get them to perfuse. I think there's if you look at the guidelines, they kind of say consider epi based on the guidance of an experienced clinician.
Right.
So if the patient is if it's thought that it's going to help them, then it is still in the toolbox. But it shouldn't be like, oh, we gave epi in there, we got ROSC and we're done. And you may. I think there's also some theory around that too, right? You're gonna hurt the grafts and things. I don't know if that's based on, none of this. This is all expert consensus, right? It's not based on a randomized trial or probably any sort of real data. It's just mainly theory. So I think if you have a patient who's coding and you're kind of preparing to open the chest and things, it's something to consider. But if we think about the data for epi in general, and with that recommendation, it's a totally reasonable thing not to give it.
I think it's one of those situations that falls outside of the algorithm for cardiac arrest because it's a very specific type of cardiac arrest and a very specific type of patient population where more often than not it's a mechanical reason for arrest. You know that. Your job is to get them to where you can fix the mechanical problem. So high dose epi doesn't really get you necessarily where you need to be if you have a mechanical problem that's restricting flow, right? So that's why the utility isn't there for everyone. You need to figure out in your situation whether or not you need a little bit extra squeeze from a pipe standpoint because the pump's not working, right? Your job is to get the pump to work again. And then you're left over with a ton of epi in circulation sometimes, and that can be a problem. So we're not saying don't use it. We're just saying, like, in terms of like your systematic approach here is to try to work your way outside of that algorithm where you're sort of anchored to where you have to give epi every 3 minutes. Like try to quiet that part of your brain down and readjust it to what's happening, right? In your post-cardiotomy patient, right? As opposed to being in like your ACLS, on Kellerman 8 or whatever, where it's just like epi, pause, epi. You have the one job, and that's to reestablish flow and to get it done as soon as possible. Does that make sense?
Yeah.
I don't know.
If it sounds like a really a primary bleed issue,
Yeah.
so like you put a chest tube in and it's just dumping blood.
Yeah.
Because of that, you think it's hemorrhagic shock.
Yeah.
In that case, would you not? Like epi would probably worse than that, right?
Well, you have to perfuse, right? So if you can't get blood, if you can't put blood in faster than blood's coming out, you're in a world of hurt to begin with, right? So your job, again, is to try to maintain that patient to the operating room where you can get mechanical hemostasis. So using pressors,
Okay. Oh, the TV.
I think it's the TV. Yeah, so, in that situation, you do whatever you can to sort of maintain perfusion. But blood would be the treatment of choice. But you don't want to leave them hypoperfused, on the way to the OR just because you can't get enough product in in time. So yeah, we still use the vasoactive drugs.
Is it a similar situation for any other improved jackets? I think the CS used to recommend 300 units in terms of.
Yeah, I think it's a reasonable thing to do. I think a lot of these things, right? We do this so that it's not. So hopefully you have some mental model of what to do, and obviously when this happens, there are probably going to be some things that fall off of your mental model because of how much stress you're in. And so I think the most important thing to realize is two things from this is one, think about do they need the pacer to work? If they're asystolic, to pace them when that's not part of our typical algorithm. And two is making preparations so three things. So pace, shock, and be making preparations to open the chest. And if you keep those three things in mind in these stressful situations, the rest of what you do, I think it doesn't really matter if you fall towards what you know.
Because doing nothing gets you nowhere, right, in these situations.
At least I'm up to date. Your cardiac can start at 10 and go up to 50.
Okay. Super. There we go. Up to date is always better, right? Start at 10, go to 50. All right. Adisa, do you have any pearls for the group?
I missed most of it.
I know.
Can we go over again?
We talked about your grounding and how it still fascinates all of us to watch you guys move very quickly grounding
So
patients?
don't be afraid of a pacer. If they're dead, you can't kill them, right? They're already dead. No matter what you do, you can just help. Grounding is easy as long as you can find the needle sharp enough to go through the skin because they took everything away from us.
Grounded, okay.
Yeah, and take a big bite. Like, don't be a chicken
Yeah.
shit, right?
Don't be
Like,
afraid.
you know, because sometimes these patients like are in block and sort of still awake, and you're trying to get it to work again. So, you know, take a big bite. Sharp needle, they'll feel it for a second.
Usually when we do that, we have alligator clips that we clip onto the needle. It's much easier than these, but right now we can't find them set alligator clips. Sometimes we pace our patients just to help their hemodynamics. A lot of times we'll A-pace them just for cardiac output. Sometimes we A-pace them just to prevent AFib, that's Dr. Rosenblum thing, and their heart rate might be 80 under that, and we'll just pace them at 86 just for that reason. I don't know if it works. I don't think it does, but we do it anyway.
The data would say not necessarily, but when,
Yeah,
you've been doing it for, you know,
It's
for
like we don't do it
30
for
years,
me.
you know,
We do
what
it just
works,
to do it.
works, right?
If they're in 2-to-1 block, it's usually better to sense their atrium, pace their ventricle. They usually have better blood pressure if you do that. So if you come in and you look at the pacer and your rate is set at 50, but their heart rate is at 90 and it's pacing, it's because their atrial rate is 90 and you're just pacing the ventricle to match the atrium. Usually it's better if they have their atrial.
Makes sense.
And the sensitivity, you already went over it. So if you come in and you want to pace somebody even though they have a rhythm, you want to pace them because their pressure is going to get better for whatever reason. You have to change the sensitivity. The higher the number, the less it cares about what the patient's heart is doing. So it's like you saying, I'm just going to take over, I don't want to care what their heart is doing. So you increase the sensitivity to override it.
Where do you cut them? You cut them before they go out to the floor, or do you just cap them and send them?
No, so we cut them. We used to pull them, but it created too many holes in the ventricle. They had to go back to the OR. So now we cut them. We never pull them. And actually, there's a patient that came back yesterday. She has an opening on her chest tube site, and everybody freaked out because they can see her base wires. So the outside hospital changed her back.
Okay.
And Bowen said, "Well, just pull him." Like she's uncommitted. Did you want another case today? Some patients do come back. Wires migrate out. Most cases, if they're actually completely out for the skin, we do pull them. This patient, like you can just, if you push on it, you can see the base wires, but she's uncommitted, so left right there.
But not
It
something that
doesn't
you'll
really-
generally be able to use on the floor like post-op day 6 because they're cut, not capped anymore, right?
They're cut.
Yeah.
Usually we cut them.
I remember we used to pull them. I remember being like on a Saturday as a fellow, you would like wrap them up and then you like pull tension. You could feel the heartbeat against it, and you would let the heart naturally beat the wire out.
Sounds like
I'm a medicine
feeling
now.
a fish, like
That's exactly what it feels like, and I can remember probably 2 cases when I had one atrial hole and one ventricular. I think that's what happened to Neil Armstrong. They pulled the wires and not him not died.
Yeah. We had a couple patients that didn't die but had to go level 0 back to the OR. So once they're cut, they can get an MRI. Please don't send your patients an MRI and get pacer wires intact because that's never good.
you guys know how to see if they're capped or not? I mean, obviously the pacer box would be not on, but so there's a little like it's like it looks like just like that green thing, but it's kind of like a white and blue, or clear and blue, and there it will sit right underneath the sternotomy dressing.
Any other questions?
We did not talk about modes. We can talk about that real quick. So there's 3 letters that we go with the pacer. So there's actually 5, but 3 that we kind of care about in the way that we pace patients for emergencies. So there's 3 letters. Anybody know the acronym? PSR, right? So pacer. So the first letter is going to be what are we pacing? So there's three main options. So V, so A, V, or D for dual. So A is atrium, we're pacing the atrium. V for ventricle, we're pacing the ventricle. D for dual, we're pacing both. S is sensing, right? So we talked about the sensitivity. We don't want the pacer to go off when the patient has a native rhythm. So again, we can sense the A, V, both, or we can have nothing. So if you set the sensitivity on that to the maximum, I think it automatically kicks over to be a 0.
So our sensitivity on these pacers, we only go from atrial is 0.5 to 2.5. You can go higher, but we usually don't. And then ventricle is 0.8 to 2.5.
You have to hit like the menu button.
And they usually don't go over 20, but if you get the emergency, it goes to 25. So if you hit this, I'll go to sensitivity, so you can see your atrial sensitivity, and then you can dial it whichever way. And then if you keep hitting this, it's going to go through. That's what you need. And then usually if you just want EDI, you can just completely go down to -0 on the A. It's going to default to EDI. And just unplug it.
So you can bring this down to 0.
It's going to
Yeah. And then so R, what's R? Response, right? So response, like what do we do with this information that we sense? So if the patient is, so usually it's, so it can either be nothing, or we're going to inhibit what we just saw, or dual, we're looking at both the chambers. So the I and D kind of make the same thing. But so let's take an example. So let's say the most common mode we use in like a patient we're putting in an emergent pacer is V, V, I. So we pace the ventricle, because that gives us cardiac output. We sense the ventricle, so if they have a native QRS, then it will suppress this, and I defines that we're going to suppress that. If we had VVO, doesn't make much sense. It's actually going to be 0, because we're not going to do anything with the information, so why would we sense? And then the other common one we'll see is going to be DDD. So we're pacing both chambers, we're sensing both chambers, and we're going to inhibit the response to both of the chambers pacing based on what we see. So if the patient has normal sinus rhythm, we're not going to do anything with our pacer. If the patient has an atrial, an A wave, or say a P wave, but they have no QRS, then we're gonna just pace have a QRS spike or a ventricular spike after the native P wave. Cool.
So that's your A sensitivity basically. You're going to sense that. So you have to decrease the sensitivity on the A, so it knows what the patient's heart rate is. Just remember, off-pump CABGs sometimes have no wires. They go, it's valid. Have fun.
And then one last thing we didn't really touch on is always keep in the back of your mind is is this patient hypotensive? They're not bleeding. Did the graphs go down? So did the graphs go down? It's not that common. I haven't seen it in my take care of it, but it definitely happens. I know Mike, Dr. Coach, had one pretty bad one when he was a fellow, where it was kind of a in sequence graft. That the first one went down and then everything else went down. So.
I guess to that point, I just recently learned that surgeons don't like it if you give someone a nitro. Because it's very uncommon for them to have ischemic pain from the graphs going down.
So usually, more often than not, rather than having classic anginal pain when the graphs go down, you're going to have hemodynamic compromise, new wall motion abnormality, or a new arrhythmia. So yeah, vasodilators that you would give for medical anginal pain probably wouldn't do anything for you except potentially worsen hemodynamics. And this again would be a mechanical problem. The most common, graft thrombosis in the periop day 1 or day 2, I've never seen before. Kinking is the most common reason to have graft failure, and that's why you would see it. Graft failure is something that everyone talks about, 6 weeks to 6 months after the fact, right? What you guys will see in terms of graft failure is mechanical failure right out the gate, and that usually comes down to somebody sewed through a graft accidentally, it kinked off, or the graft wasn't long enough and it kinks off or something like that happens. Again, very rare, but usually will result in new regional wall motion abnormality and hemodynamic changes before the patient complains of chest pain. Chest pain in the periop cardiac surgical patient, your differentials are much higher for pneumos and medical pain or pericarditis. So again, ST changes post-op day 1 with chest pain and a new friction rub are almost universally the result of pericarditis. And you can have focal pericarditis, which will still cause you tons of stress at 2 o'clock in the morning when you have isolated ST elevations. Again, that's why, conversations and care escalation, and part of this that we didn't really hit on as much, and we continue to, is that there is a care escalation pathway, and you guys need to be discussing this no matter how comfortable you get. The more comfortable you get with cardiac surgery, the sooner you're going to call your cardiac surgeon, not the opposite, right? So even when I know exactly what's going on, the first person I'm going to talk to is the DSET and the surgeon, right? So that we're all on the same page. I think that's very important. Because it'll help you in those cases where even if you have focal pericarditis and you're sure this is a STEMI, you don't really get STEMIs in the periop area. You get graft failure and then you get heart failure and then you die, or you go into a lethal arrhythmia, you go into VT or VF or something like that. So something it's a little bit different, but yeah, something to think about. But it's still, I think it's ingrained in all of us to see ST changes, patient has chest pain, beta blockers, sublingual nitrate, morphine. Now I'm going to go work it up, but you can find yourself in a world of hurt in this population if you take the same approach to chest pain, because it's a different cause, different etiology with a lot of other things that can sort of cycle out of control. So that's why, we work through these things, you get experience. Trust me, we've all ordered troponins on post-op heart before, and we've all taken it on the chin. Speaking from experience, right? So I've been there. That's why we're doing this, right? Because Chris and I live this world, right? As a trainee, and that's why the only thing that you can do is arm yourself with as much experience and education as possible, and that's what we'll do.
And nobody's ever gonna yell at you.
Never. Nowadays, I feel like we need to go back to more young. It's so nice.
That's soft.
Cool. Any other questions?